So what Martine's asked me to do is really just give you a little bit of a broad overview, and anyone who's heard me speak, I think feel free to interrupt if there's anything if I say which which is not clear, and we will do questions afterwards. And obviously it's going to be focused around PSC. It's going to focus a little bit about how doctors diagnose PSC, a little bit about the disease, and a few things about how we'd like to get better drugs for our patients. But as I said, it's informal, it's a Saturday, everyone's welcome to, put your hand up, say, you don't understand, etc., etc. What I've started to do is, for most of my talks, is to include this vision statement, okay, which hopefully is trying to give you some idea as to what we're trying to achieve as all the clinicians who look after all the patients with autoimmune liver disease. And fundamentally what we're trying to do is to move your disease from the doldrums, in the broadest sense, to the forefront of the NHS and to get new treatments for patients, okay? And to not let there be a laissez-faire approach that says, oh well, it's all right, it's rare, it doesn't matter, okay? So we're after better treatment targeted in better ways, which addresses two things, which we know are important: quantity and quality. And this clearly is a journey, and it's going to take a long time. I'm afraid it takes, on average, 17 years from a scientific discovery to a new medicine. Okay, and people have tried really hard to speed that up, but that is approximately how long it still takes to this day. But we'd like to do better. And we want drugs that are safe, tolerable, and effective, and given to the right people. So that if you don't need a drug, you don't need it, but if you do, you do. And that drugs have been proven in the right patients to work. That means that the right people go into clinical trials. And I'm afraid all drugs will come with side effects. There isn't going to be a drug that is side effect free, okay? But we hope that any new drugs will have manageable and tolerable side effects. So there'll be a balance, and that balance will be met. But I mean, the goal of the perfect therapy is not plausible. Okay. So I put up this slide because I must have pinched it from the internet for two reasons. One is to make sure everyone remembers that their liver's on their right and their spleen's on their left. Okay, so that's important from a pure anatomy point of view. And the second thing is that we treat patients, not numbers. Okay, and so we do a lot of research on large cohorts of patients where we learn a lot about what predicts a disease in terms of a gene or a blood test or a picture, okay? And we use that to inform you, as we discuss in clinic, what we should do. But at the end of the day, we try and personalize it to the person, okay? And, one number is just one number, but there's only ever one patient. Okay, and so what's right for somebody else doesn't always have to be right for you, and vice versa. Obviously there are themes and there are groups, and some groups of patients are more like each other, and etc. But that's why I use this slide. So there's more than just a single test, and it's about the whole of you. And then within the liver, the way you need to sort of think about it is it's a pretty clever organ, I guess. It's quite large. It's really full of two important cells. The hepatocytes, they make things, particularly around proteins and things for the immune system, and the bile ducts. And actually the hepatocytes make the bile acids that then go down the bile ducts. And the tricky part for PSC is that, unlike some other bile duct diseases, it tends to really focus on the larger bile ducts. So here you've got the common bile ducts coming out of the liver, draining bile into your bowel. It's just at the end of the second part of the duodenum, it sort of joins in. And it's come from branches within the liver. You've got the left and the right ducts, and you've got branches above that, like a tree. The challenge is that, unlike a disease that attacks the millions of teeny weeny little bile ducts, PSC goes for the large bile ducts, okay? And you can tell from the picture there aren't very many large bile ducts, and therefore the consequence of injury is dependent on where that injury occurs. And if that injury occurs in the main common bile duct, which is draining bile from your liver, you will go yellow. There is no alternative way out for that bile. Whereas if the injury is further up into the smaller bile ducts, obviously then that liver can cope a lot longer. Okay, so that's the purpose for this slide, just to remind you that the bile ducts are, of course, completely part of your liver. So it's not like you can take out the bile ducts and then not worry. Unfortunately, they are part and parcel. So what does the liver do? Okay, so it makes proteins, and it makes a lot of important proteins. It makes the proteins that you need to clot your blood. It makes proteins that are required to carry vitamins around, to carry chemicals around in your blood. And actually, it's really important for making defense proteins for your immunity. It's actually why hepatologists worry so much about infection, because when the liver's poorly, the whole liver, not just the bile ducts, then patients are at higher risk of infections. It's there to detoxify chemicals. In fact, that's really what the biliary tree is doing. It's doing a number of very important things about getting bile into your bowel so you can absorb your fat. It's about bile acids going down into the bugs in the bowel and then talking to those bugs and then sending hormones back to the liver. But also, actually, it's about getting rid of chemicals that we all encounter all the time, and there's nothing you can do about it. And probably one of the reasons why you get these diseases will be things in the environment, and presumably it's because the liver is so important in detoxification. That is why it might be a trigger for some disease. And then, of course, it produces the bile that, as you know, if you're very yellow, then you won't absorb your vitamins, and Jill will give you a much better insight to that than I can. Now, for most people with liver disease, which is good but also a challenge in our practice, they have no symptoms. And we don't actually, in medical practice, define what a symptom is. It's obviously defined by patients. But for the large part, you can have a lot of liver disease and you can just have no symptoms at all. If you probe more, and Martina has done that by doing surveys with you guys, and there have been formal surveys done through clinic practices, what you see is tiredness, but that's not specific to liver disease or a liver disease, it's specific to life, but it's clearly there. And fatigue is clearly an important symptom, and for some people it's particularly prominent. For other people it's something they notice but they get over. Itch is more specific to liver disease because something within the bile makes you scratch. Now, we don't actually know what it is to this day. It's amazing. In fact, yesterday we had a meeting on PSC. We didn't talk about itch, but there are still people out there who are looking at ways to measure itch properly. It's a really hard symptom to live with. It's an even harder symptom to study because itchometers don't exist. And how do you measure whether someone scratches more or less? But you actually need to go into that kind of thing if you want a drug to improve itch, because you have to prove the itch was less. We actually rely mainly on our patients, and now using these sort of, these clever phones, smartphones, you can have apps that you can measure your itch twice a day, and it gets uploaded into the trial. We haven't done an itch study in PSC, but we've done some in PBC. Pain is very important, and pain in your liver is real. We don't always explain it. I guess sometimes we think it's due to a liver being stretched. Clearly, when the liver's infected, then that can cause pain. Actually, the bit where you go yellow is actually quite rare, fortunately. It's very important and we take it very seriously, but fortunately it's at the end of the disease usually. The disease has been around a while and it's caused sufficient damage. Okay, so what is it that we do when you come to clinic? So at the moment, and maybe in 20 years' time, this talk will be delivered by artificial intelligence, and you'll get Siri doing the talk from Apple. At present, what a doctor does is basically synthesize, okay? And what our goal is to listen and put the pieces of the puzzle together. And that's why I said no one piece of information actually determines what we do. So we focus on the whole message rather than the bits of the message. So we listen to the story, we may examine you, okay? We'll look at your liver blood tests, but they are just blood tests, they aren't you. We'll look at what it looks like, and that's really where we've had the greatest advances is radiology, look without touching, okay? It's become more and more sophisticated, and every now and then we will look under the microscope. So I'm going to talk about some of those components. We'll actually do a liver biopsy, which is understandable because this is a liver disease, and you wouldn't take your car for MOT and be completely satisfied if the guy only just looked at the exhaust and said it's all okay, without opening the bonnet. Now, doing liver biopsies has a different impact, of course, for patients. It's not quite the same as taking your car to quick fit, but every now and then it's the right thing to do. So, the bloods are just bloods, but they are enzymes that are actually important in their own right, which don't really have any function in terms of PSC, but they're enzymes that if your liver is inflamed, leach out, and we can measure at a higher concentration in a blood sample. Okay? So it's peripheral to the liver. It isn't the liver, but it's what we would call a surrogate of what's going on. Okay? But, just as this cartoon says, sometimes it's barn door obvious what's wrong with you, okay? But we'll still probably do some blood tests just to play it safe. Okay? We're doing them for a number of reasons. We're tracking things. We're trying to see trends. Okay? But they aren't the be-all and end-all, and your blood tests can be normal, and you can still have a problem because they only tell you as much as they tell you. People always find it quite hard to understand that sometimes we have patients who've got quite significant scarring, but their liver tests are normal. And to a hepatologist, that's not a surprise at all, because some of the blood tests have to come from those liver cells, the hepatocytes. And if your hepatocytes have been used up and what you're left with is cirrhosis, well, then your liver test won't go up because you won't be able to make those enzymes. And what these enzymes are, and this is just a picture of a liver cell with the two sides of it. One side abuts the bile ducts, essentially. The other side talks to other hepatocytes. These are liver enzymes that are metabolically part of the metabolic metabolism, and they're each doing something in terms of metabolism. But if that liver cell is injured, they leak out. And so the ones that we look at are the ALT and AST, and we tend to look at that around inflammation from the liver cell. And the ones that interest us around the bile ducts is alkaline phosphatase and gamma GT, and they're more on the bile duct side, and they go up if the bile ducts are teased, if they're inflamed. What a hepatologist does when they look at those blood tests is really help them decide what the pattern of injury is, not necessarily the severity of the injury. Okay? So I'm using it as a targeting device to say, what is the prominent process going on in my patient? Is it mainly liver cell inflammation, or is it mainly bile duct inflammation? Because the peak, or how high that test is, may not be associated with the severity, for a number of reasons, one of which I told you is that, for example, for ALT, which is a marker of liver cell damage, well, if you're a very young, healthy person who gets a liver injury, your ALT will go sky high because you've got a really healthy liver and there's a lot of enzyme to leak out. Whereas the same injury in somebody with maybe cirrhosis, the ALT may not budge at all, or it may just flicker a bit. Okay? But it still points us in the direction of travel as to what to look for with more complex tests. It's less relevant to PSC than it is to some other autoimmune diseases, but patients who have autoimmune diseases often make antibodies against themselves. So certainly, if we think there might be, and I know people get very hung up about it, overlap, an additional injury like an autoimmune hepatitis injury, we may look for the antibodies that are associated with that particular form of autoimmune disease. And we do that by our immunology labs. In Birmingham, actually, the immunology labs are in the university, just across the road. And they, again, give us clues, but are not diagnostic. So we often, plenty of you will have anti-nuclear antibodies and anti-smooth muscle antibodies, which mean absolutely nothing from a practical perspective. So we don't hang our hat on a single result and say, because you've got that, you must need a specific treatment. It's all part of that jigsaw. Why do we like ultrasounds so much? Because they're cheap, because they don't hurt particularly, there's no blood, and they tell me quite a lot about the shape of your liver, the size of your liver, and the size of your spleen. We don't really use the ultrasound to look for bile ducts. It's quite unusual to get bile duct dilatation, except when you've got like a big whopping gallstone in your common bile duct. So in PSC, you sometimes can see the inflammation in the bile ducts. If you're lucky enough to have a really good radiologist do the ultrasound, they'll tell you that there's thickening of the bile ducts. They'll just subtly see it. Okay, but generally speaking, we don't use an ultrasound for that. But we do like to know what's the shape of your liver? Has the size changed? Has it got smaller over time? What's happening to your spleen? Okay? It tells us about the risk of you developing scarring. MRI we like, and I will admit I have had MRI and the MRCP, because many of you have been part of Pete Eddowes or Perspectum have got one of their scans, and we've been doing a lot of those, and Katie's now approaching lots of patients in clinic to have an MRI and to have a scan to look for inflammation and scarring. So it is a little bit tedious to be stuck in that tube for up to an hour, wondering if the radiographer is going to come and get you out, and knowing that if you sit up, you'll bang your head, okay? And then when they tell you to take a deep breath in for 60 seconds, wondering why they waited 3 minutes before they told you to breathe out, okay? And you're trying to work out, could they not get that a little bit better? But it's an important test. But it's really hard. It's hard for you because you have to hold your breath, okay? And actually it's not that easy to interpret, which is part of the reason we're doing some of the studies, is actually we need better MRI. Because, you know, it's a bit grainy. That's a good picture of an MRCP. This is a reasonably good quality MRCP. But if someone breathes or they move a little bit, you can get a little bit of artifact, and what you get is a grainy appearance. And you wonder why your radiologists then struggle sometimes, particularly to talk about the smaller bile ducts, to say whether they've seen anything. So, many of you who come to my clinic always wonder why I want to have an MRCP done in Birmingham, not somewhere else. It's not because I think our scanner's any better. It's just because I know how hard it is generally, that if we are going to do it, it's just helpful when it's looked at by the same person on the same scanner to try and, to compare what may be subtle things. Because, you'll be interested to know what your MRI shows, and what we have to do as clinicians is help you, that's an opinion from a radiologist. They haven't got the rest of the information. They haven't necessarily got the blood tests. They haven't got you in front of them. They don't know the rest of the story. They're telling you what the picture looks like. And what we're doing is putting the picture into context. Okay? So, you can't just read the words of the report to understand what it means. But it's very important. We have no idea how often to do them. We probably do them too often at the moment, but hopefully by doing them too often we'll learn and we'll get it right. Biopsy is worth mentioning because for the large part, biopsy's gone out of practice in PSC because we don't need it to make the diagnosis, because your blood tests tell us that there's a bile duct problem. Your antibody tests tell us that it's not your small bile duct disease. And then maybe you got colitis, maybe you haven't, but once you put those three things together, you'll do the MRI and you'll see the large bile duct changes of PSC, and you don't need a biopsy to prove it. Additionally, because the biopsy is still a relatively small piece of liver. But it is actually a good test because it is the disease. We are quite good at looking down the microscope and measuring scarring, and it's pretty objective, and in some ways it's a little bit more objective than MRI. Okay, so we could do a biopsy, I could send them all over to the States, and one person could look at all 200 of them and compare. So it does actually have a role, and it may have a more frequent role in clinical trials in the future. It might come back into practice. It is a tiny piece of tissue. You don't need to worry, it will regrow within about a day. It's a slither, okay? We do it as a day case. Generally nowadays, increasingly it's done by our radiology colleagues, which makes it a lot slicker and a lot quicker, but there are risks, and some patients get pain, and there's inevitably some patients will have a risk of bleeding. Okay, so what does your liver look like? Well, if you take out the whole liver, and this is obviously a healthy liver, what you've essentially got is, hexagons, okay, where you've got a vein in the middle, and then what we call triads around the corners. And those triads are draining in blood, and then the blood, which comes into the liver through the portal vein, is percolating along the liver lobule right to the middle bit to then go to a vein to go out. And it reproduces itself throughout the liver. So that's a very, very crude description of liver histology. If our pathologist was in the room, he'd probably have walked out by the stage. Okay? But in essence, that's what happens, which is actually why when we do a liver biopsy, we often see a lot of information around the entry point, which is where the blood's coming from the bowel, because that's the first point where the blood has hit the liver, and that's often where you get the immune reactions. Okay? But that's a healthy liver. And again, this just makes it a little bit bigger. You've got your central vein, and then in this triad, you'll have three things. You'll have a small artery, hepatic artery. Remember, there are two blood supplies to the liver, the hepatic artery and the portal vein. The hepatic artery is a bit like the blood coming off the M1. The portal vein is the blood coming from the bowel. Approximately 2/3 of the blood comes from the bowel actually, but it's obviously under a lower pressure. And then next to those two blood vessels, you've got a bile duct. And the curious thing is that the bile duct is very, very dependent on the artery for its survival, not the portal vein. And that's one of the reasons why we have problems after transplantation. If the blood supply is interrupted in the artery, the bile ducts don't like that. Okay, they really don't. Okay, but blood comes in, and then essentially it percolates all the way down and then goes out again through the central vein. And as it's percolating, the different cells are adding or subtracting. So that's how it's doing its function. So this makes, you can just see this in larger detail. This is probably not human actually, I think this might be animal, but it's the same concept. Small artery, small bile duct, big portal vein, and that's the so-called portal triad. Okay, so that's often why when you first see liver injury, you see it around here, because that's when the first blood has hit the liver. Okay, so very important, and that's what we're looking for down the microscope. And you might also wonder why we often get the biopsies reviewed. Intrinsically you'd think, well, if anyone looks at it, they'll know what they're looking at. But actually it's quite hard, bile duct disease, to look down the microscope. And so most of our pathology colleagues who work in smaller hospitals are general pathologists and may do a lot of viral hepatitis C or a lot of fatty liver, and therefore their eye, it's an opinion, is trained more around liver cells than bile ducts. And actually it's quite hard to see these little bile ducts and to really get your cortex to pick up changes. And that's why we frequently have our biopsies sent over to our pathologists who just do liver disease, who are very much trained to pick up subtle findings and who will cut the section deeper, will get more sections and do extra stains, and sometimes come up with a slightly different opinion based on what they think, because they just do it more. This is what you want to avoid, obviously, okay? But this is why cirrhosis is bad for you, okay? It's fundamentally obvious that that is a small, shriveled up walnut of a liver, okay? And it's clear that a liver that's the wrong size and shape is not going to do what you want. It's not going to be able to make the proteins you need. It's not going to be able to fight infection properly. And again, that concept that blood percolates through in a nice way, through the sieve and then goes out the other end without any obstruction to flow is kind of obvious. It's not going to happen, is it? You can see that the blood is going to be under pressure, and if it's under pressure, then that's portal hypertension and the risk of varicose veins. So that picture is not particularly appealing to look at, but it helps you understand exactly what's going on as you get cirrhosis. But it's stages. And everyone's always worried about their stage, and I tend to refuse to tell people their stage because I don't necessarily believe in it. You go from a very healthy liver, and over time you get more and more scarring, and that's actually the nature of all liver disease. So that is important, but it evolves over time. When you've got that small shriveled up liver, the pressure goes up. So the whole idea is that blood comes from the bowel, goes into the liver, goes back to your heart through the hepatic vein. It's picked up good things, bad things, done its business, and then it goes back to the heart. Fundamentally, it's a closed system. I think we'll all agree we like it to remain a closed system, okay? So I wasn't very good at physics, but you don't want to have leaks in the system, okay? Therefore, if that liver looks like this one, pressure will go up. Okay? But the blood must get back to the heart. It absolutely has to get back to the heart, and that's when it opens up other vessels to get the blood back to the heart, which may bypass the liver, but that's so-called portal hypertension, portosystemic collaterals. So it might make your spleen big, and then your platelet count will drop. It may open up these varicose veins in your esophagus, okay? And you can see that these were not designed to take a lot of blood. The blood was supposed to be going back to the heart without these. Therefore, these have a higher rate of bleeding, okay? Which is why it's important to have an endoscopy at the right time, because generally we can prevent them from bleeding, okay? But that's portal hypertension, and that's also probably one of the reasons why, as liver disease progresses, patients also get a bit more fatigue, because when you've got portosystemic shunting, when you've got varices, that blood hasn't been properly detoxified, so it's probably containing compounds that should have been got rid of by the liver, which haven't, and therefore that will contribute to that sense of unwellness, okay? But we can deal with varices, we can reduce the pressure with beta blockers, or we can get rid of them.